Patient has a massive hemorrhage. He presented to the emergency after a road traffic accident. What do you give, what you don't give? Obviously, tranexamic acid is an antifibrinolytic agent. So fibrinolysis lead to bleeding, antifibrinolysis lead to clotting you can give. And earlier the recommendation used to be give 2 liters, but now we give only 1 liter of fluid initially compared to 2 liters is what you have to appreciate. The patient comes to emergency. Once more, doctor, trauma and resuscitation. At least 4 to 5 questions examiner will ask. You read from Bailey and Love or any book, you must be very much ready. Trauma and fluid resuscitation is a favorite area. Patient presents to emergency after a road traffic accident. How do you differentiate cardiac tamponade from the tension pneumothorax is a very, very important question. Actually, not very big challenge to discover. Breath sounds will not be there in pneumothorax. Breath sounds continue to be there in tamponade. So it's not at all a challenging question, right? So in both the cases there will be raised JVP and increased heart rate. Now the question is, a tension pneumothorax, cardiac tamponade, massive hemothorax. How do you differentiate? First, history. कोई चाकू लेके stab किया, chances of hemothorax are very high. Then somebody had a blunt injury, something came and hit, not a penetrating one, then tension pneumothorax is high. And a penetrating injury is more likely to get into the heart and lead to cardiac tamponade. In all the three, the filling of the heart get affected, and that is the reason the pulse will be very rapid, tachycardia. Blood pressure will be low in all the three. Pulsus paradoxus is likely in tension pneumothorax. It can sometimes happen possibly in tamponade, so it can't differentiate. Heart sounds are muffled in tamponade, low heart sounds. Neck veins are typically distended in the tension pneumothorax and cardiac tamponade, but the neck veins are collapsed in case of massive hemothorax. Then pneumothorax is hyperresonant to percussion, the lungs, whereas the lung percussion is normal in tamponade. The trachea is still midline in cardiac tamponade, but tension pneumothorax will shift the trachea grossly, so it is deviated in case of tension pneumothorax. And if you look at the chest symmetry, because of the tension pneumothorax, all that air in the pleural cavity compress the lung and push to the mediastinum, there can be a asymmetrical chest in case of tension pneumothorax. Breath sounds are very important. Typically they are absent in case of the tension pneumothorax is what you have to ultimately remember. So this is how the heart in a patient of cardiac tamponade looks like. Now doctor, what is the Beck's triad in case of the cardiac tamponade? So when the heart is all surrounded by a lot of fluid and not letting it to get filled, all the great veins which are trying to fill into the heart are unable to fill into the heart, hence the jugular veins will be distended. Since the filling of the heart is not there, pumping of the heart is affected and hence hypotension. And since heart is surrounded by all that fluid, you have the muffled heart sounds is what you have to basically remember. What is the echocardiographic hallmark of the cardiac tamponade? When there is a lot of fluid around the heart, what will it do? It will compress the heart. So at the time of the diastole, the right atrium is supposed to eject the blood into ventricle, and the ventricle, this is the left ventricle, you can see it is able to open up, But right ventricle, it is unable to open up because all the surrounding fluid is compressing it. So diastolic collapse of the right ventricle is the hallmark of the cardiac tamponade. खाली पेरिकार्डियल फ्लूइड रहे तो उसको tamponade नहीं बोलते. 2D को करके diastolic collapse को दिखाए तो then that is called as cardiac tamponade is what you have to basically understand. So whenever pericardial effusion is there, intrapericardial pressure is more than the RA diastolic pressure, then the right atrium will undergo a collapse during the late diastole, and RV diastolic pressure is, say be pericardial pressure if it is high, early diastole may RV undergoes collapse. Instead of right ventricle at the time of diastole is supposed to distend, instead it will show the collapse. Then similarly, during expiration, inspiration, if you have put it to the echo probe and looking at the flow, how will it look like? During expiration, you have a lot of positive intrathoracic pressure, and all that positive pressure will make the RA and RV to collapse. That is the reason if the RA and RV got collapsed, the blood cannot flow across tricuspid valve. That's the reason the tricuspid valve inflow become diminished. But at the same time, the interventricular septum is there, right? That become deviated towards the right, and the left side mitral valve flow become increased. That is what happens in expiration. Then in inspiration, there is a negative intrathoracic pressure that will suck the blood and make the tricuspid valve inflow to increase, and the mitral valve inflow will diminish. So this increased interventricular dependence with expiration and inspiration, demonstrating it on the 2D echo, is another important indicator of the cardiac tamponade. So the RA collapse and the RV diastolic collapse. Without this demonstration of these collapses, tamponade is an unlikely diagnosis on 2D echo is what need to be remembered. 2D echo is nothing, very simple. You have one parasternal long axis view, you have got a 4-chamber view. Only difference is biology teacher taught us atria are above, ventricles are below. 2D echo cardiology teacher क्या teach करेगा? देखो बेटा ventricles ऊपर दिख रहे हैं ना, 2D echo में नीचे है atria बोलेगा. Only thing is you should not confuse between your biology teacher and the cardiology teacher. But don't worry, I am both a biology and a cardiology teacher. Tension nahi hai. So this is a RA which is dilated and RV which got collapsed, and this is the LV LA, and this is the RV diastolic collapse. Now one word on the breath sounds of the heart and the percussion findings of the lungs. Breath sounds and percussion findings, let us talk. On percussion, how many types of sounds you can listen? Quality: hyperresonant, tympanic, dullness. Emphysema, all that blown out lungs with full of air, classical of the hyperresonant. Tympany, pneumothorax and a large cavity if it is there, like a TB, lung abscess, lung cyst, you get tympany. Dullness is an indication of collapse, atelectasis, pulmonary edema, or whenever there is any pneumonic consolidation and resolution stage when pneumonia jab hota hai, the lungs will show dullness to percussion on a pneumonic area. So that is what you need to understand. This is one table, doctor, on the UMedico app. इस स्लाइड को आप बुकमार्क रिमाइंडर में डाल देना है नेक्स्ट वीक से, राइट, when the feature comes. Effusion, atelectasis, pneumothorax, tension pneumothorax, consolidation. Based on the breath sounds, percussion, vocal fremitus and tracheal deviation, how do you differentiate? Pleural effusion mein how will be the breath sounds? Obviously there is a lot of fluid. It is not letting the lung to expand easily, so breath sounds are diminished. How will be percussion on the fluid? It will be typically dull. How will be the fremitus? Okati. One patient is saying you are feeling how is the touch on your ulnar side. That is vocal fremitus. It is decreased in effusion because there is a fluid. And how is the tracheal deviation? It all depends upon the size of the effusion. If the effusion is large, it will lead to tracheal deviation to opposite side. Then if there is any collapse of lung, atelectasis, then for example, if a bronchus is there, bronchus ke andar if there is a mass, then that part of the lung which is ventilated by that bronchus will undergo collapse. So that decreased breath sounds because there is a collapsed lung. It is dull on percussion, vocal fremitus decreased, but a atelectasis will pull the trachea towards its side. It will take a hug of the trachea towards its ipsilateral side where the atelectasis is there. If it is a pneumothorax, what will happen? Simple pneumothorax. It will be hyperresonant. Breath sounds are absent because there is all pleural cavity is full of air, compressing the lung into a small part. It is not expanding, so no breath sounds. So it is hyperresonant on percussion. Fremitus is decreased, but it is called simple because trachea is not yet deviated. But the moment trachea got deviated, you call it as tension pneumothorax. Then what happens in consolidation? Typically consolidation like lobar pneumonia or pulmonary edema, what will happen? Typically the bronchial breath sounds will be heard, right? Bronchial breath sounds will be heard. It is dull on percussion, but vocal fremitus is increased on that area where you have the pneumonia or consolidation is what you need to appreciate, right? Now, can you give me the board? Yeah. These things we discussed so many times. Let me tell you once more, NEET PG 2019 में examiner will give you breath sounds ऐसा है, bronchial breath sounds है और vocal fremitus भी increase हुआ, ये क्या हो सकता है बोल के पूछेगा. Then you will remember Dr. Murali Bharadwaj and this wonderful winter evening with all of you. So why the bronchial breath sounds are heard? You know very well the trachea divides into the bronchi. As MD General Medicine, we always love to teach clinical medicine, right? But the only thing is, maybe in if some of the final year students are there online, preparing for the final year exam, we also plan to bring some clinical cases. There I have a lot of pulmonologists, cardiologists who love to bring cases to the place and then participate in the live broadcast, or we can even broadcast directly from their hospital, from the clinic. Clinical medicine is all the essence, doctor. You know, there is no more happiness than being a medical student. And those first time when we have palpated, percussed, auscultated, listened the tinkling sounds, oh my God, nobody in this world will have that privilege. So you have the lung, doctor, around the bronchi. All this lung parenchyma will be acting like a filter. You listen the music using the headphones, no? So that is the reason the sound that you hear directly on the bronchus will get filtered and it has a different quality by the time you listen if the lung filters it. But if you are having any consolidation, pneumonia, then this filtering ability of the lung parenchyma is gone. Directly the quality of the sound is the one which is you hear on the similar to trachea or bronchi. That is called as bronchial breath sounds is what you have to basically remember, right? Now doc, let's take up the next question. Patient is in emergency room, road traffic accident, conscious, speaking single words, respiratory rate is 40, BP is decreased. What is the next thing that you want to do? Obviously, it is a case of pneumothorax. For the pneumothorax, when he has a lot of respiratory embarrassment, you have to treat by doing intercostal drainage tube. And what is the location where you want to put the intercostal drainage tube, doctor? Fifth intercostal space in the mid-axillary line is the classical location where you put the intercostal drainage tube. And suppose if it is only a small emphysematous bleb which got ruptured and there is a pneumothorax small in size, then urgently in the ward, if you want to take care, then second intercostal space in the mid-clavicular line also you can pass a needle and then gush out the air is another important mechanism is what need to be remembered. What is the most conspicuous sign of the breast cancer? Is it PUD orange or is it the puckering? Big challenging question. Sometimes knowing PUD orange is more than enough. What is the PUD orange? Because of lymphatic obstruction. The surrounding lymph nodes, lymphatic channels, they got fibrosed. So lymphatic drainage is not there. That lead to that peeled out orange appearance of the overlying skin in breast cancer. So this is the typical PUD orange and the skin retraction and puckering. So like the orange peel ka skin, the skin is is the typical PUD orange. I still prefer puckering of the skin a more reliable feature because all cases of breast cancer you don't get PUD orange. Typically 80% of breast cancers you get skin retraction and puckering. There is a productive fibrosis and that typically lead to the involvement of the stromal tissue. There is a desmoplastic reaction. Because of that, the Cooper's suspensory ligaments are fibrosed and that lead to development of the skin retraction and puckering seen in 80%. Conspicuous का मतलब क्या होता है? English dictionary देखना पड़ता. But PUD is only in inflammatory breast cancers where there is a lot of localized edema, interruption of the drainage of the lymph node, lymphatic fluid, and that lead to the PUD appearance is what need to be remembered. Rails tube डालने के लिए neck को flex करते या neutral position में रखते. Don't use the practical knowledge. I know what your assistant professor taught you. He didn't teach anything. Actually, Sister Mary will teach this kind of tricks. Sitting with a neck slightly flexed will enable you to do it. So earlier NEET PG question bank they asked a question, what is the length of the NG tube? Start from, you call NEMU. NEMU is the acronym. Nose, ear, up to mid umbilicus. पूरा calculate करो length कितना है, उतना length वाला Rayleigh tube is what need to be remembered. So, why the flexion of neck will help you? So, when you are passing the Rayleigh tube, lot of times it is the arytenoid cartilages etc. They will actually make array epiglottic folds. They are the ones which will interrupt the passage of it. So, if you do neck flexion, the nasogastric tube's curve will come in alignment with the posterior pharyngeal wall and that will facilitate a smooth passage into the esophagus is what you have to basically remember. So, that is the reason the recommendation is make the patient to flex the neck. In fact, you can ask him to drink some water. For drinking water, you have to flex the neck, no? And you can then put the nose का काम nose करेगा, मुंह का काम मुंह करेगा. But मुंह से पीने के लिए you have to do the flexion of the neck. That is enough for smooth passage of the nasogastric tube is what you need to remember. Very practical. AIIMS guys are very practical guys.